Well, welcome to this talk. Now, a few days ago, we talked about increasing cancers in younger age groups. And what we need to do here is get more data so that trust can be restored, because at the moment there's a deficit of trust. So what we need to do is have a better, more up-to-date breakdown of who's getting what cancers at what ages. That clearly needs to be in the public domain so that statisticians can analyse it, and then fears can hopefully be put to rest. And we also need much more in terms of histology and genomic analysis, and we're going to talk about this later in the video with evidence, that if someone gets a cancer after a COVID vaccine, especially if it's shortly after COVID vaccine, especially if it's an unusual type of cancer that presents very quickly or presents at a very late stage, very often without too many symptoms before it presents at a late stage, then that needs to be genetically sequenced. We have the technology to do this. Then if there's any promoter sequences, for example, that might have been in vaccines, then that can be identified. Of course, if there's not, then the public can be reassured. We need this transparency. But let's just remind ourselves about the issue of turbo cancers first of all, and doctors around the world that are talking about it. Just a very brief clip from Mr. James Royle, consultant surgeon, that we looked at a few days ago.
Particularly colorectal cancers. In addition to the increase in all-cause excess deaths in highly vaccinated countries since the gene-based injectable rollout, there has been observed an alarming and significant increase in cancers. These cancers have been termed colloquially turbo cancers. Obviously, this is not a scientific term, but reflects the different aggressive biological nature that seems to be being observed by the public as well as clinicians.
Now, Mr. Royle there talking about his own practice, but also concerns from the public. And of course, if you read the comments under my videos, there's been thousands of you who've been affected by cancer, either yourselves or close relatives or loved ones or friends or acquaintances that have got cancer, what you perceive as being at a young age in sometimes in somewhat unusual circumstances. But what about the situation in the United States? Well, I'm going to play a short clip now from Dr. Paul Merck, who's one of the world's leading physicians, incredibly highly qualified, decades of experience, and extremely well published in research and academia. Let's listen to his perspective now.
What can you tell us about this emerging term called turbo cancer?
Yeah, so this is a really important question. So by turbo cancer, we mean cancers that are turbocharged. So these are cancers that are occurring in young people. Generally, cancer occurs in the more elderly, but we're seeing an explosion both in the US, in the UK, in Japan, in cancers between the ages of 14 and 44, a rapid increase. We're also seeing patients present at a late stage, stage 3 or stage 4. So these are patients presenting late, and then patients presenting with very aggressive cancer. And so there's no question that there's been a change in the characteristics of cancer. And there seems to be an association, it's still controversial, between vaccination, particularly the boosters, and the development of turbo cancer.
Now, when the world's leading doctors raise concerns like this, these should be acted on and answers should be given. So Dr. Merck there describing increase in cancers in 14 to 44-year-olds, a rapid increase that he's seeing. Later presentations, often presenting at stage 4 when it's metastasized around the body and it's too late to do anything. Very aggressive cancers that are developing and spreading rapidly, and he's noticing a change in the characteristics of cancer. So put these things together and we've got a change that needs to be explained. And as we've said, we need the data to do this, and we need more scientific analysis. Now I'm going to play a clip from Dr. Clare Craig now. Now Eddie Hobbs is on X as Eddie Hobbs 1215. He facilitated the People's Vaccine Inquiry for Ireland. And as always, Clare gives a very detailed analysis of the situation, very data driven, but points out these highly practical things that we need to do to answer the questions. Then we can say, yeah, you know what, there is an issue here, or hey, no, this was all for nothing, there's no problem at all actually. But from the combination of evidence from these experts, I remain concerned and still wait to be reassured. But over to Dr. Craig now.
So yes, the SV40 sequence should not have been there, wasn't declared to the regulator, and any bit of DNA that says make me has a potential, hypothetically, of causing cancer, because cancer is when you have unregulated growth of a cell, and if you have a bit of sequence that ends up inside your cell that ends up saying make me about something that makes your cell grow, that's a cancer risk. And so that's why people have raised the concern about cancer in respect of this. And what we haven't yet seen happen, which is really urgently needs to happen, is that people who've had cancers after the vaccine, those cancers need to be sequenced and studied in a laboratory to see if that is what's happening in these cancers. And so that's a big unknown that remains. And I'm not saying that this has caused lots of cancers. I'm just saying that there's a huge question there that needs investigating.
So we've looked at this SV40 promoter, which is a contaminant in vaccines before, in the RNA type vaccines, at least in the Pfizer one that we're talking about here. And if that is causing the cancer, then it's quite possible to look at the genetic sequences of those cancers and see if we're finding that contaminant in the cancers. This is a simple thing, relatively simple for genomic laboratories anyway, that could be done. And Claire points out the complete obvious there. Combine that with the extra data that we need, and hopefully minds can be put to rest that this isn't a problem after all. But there's a question there that needs to be answered, so I agree completely with Dr. Craig that this needs to be answered. Let's look at a little more of this inquiry, because there's more interesting material coming up in a minute.
But is there any evidence? I mean, I just stumbled across some stuff coming out of Japan. Dr. Fukushima, I think, if I'm pronouncing it correctly, seems to be an oncologist, seems to be quite concerned.
Oh, absolutely, and he's not the only one. So there are plenty of professionals who, in their oncology work, have raised concerns around the types of cancers they're seeing, the age at which they're seeing them, the stage at which they're presenting, so they're presenting very late on in their patients, the rate at which they're progressing, the fact they're occurring so soon after booster doses. And so all of that is information that I take seriously, and you might dismiss it as anecdotal, but every bit of anecdote is, that's where we start with science. You start with observing something, and they are observing this phenomenon. Now, what we see in the data is that at least in England and Wales, there is only 1% excess for cancer mortality. There shouldn't be an excess because we've had a lot of death. And when you've had a period with a lot of death, there should be a deficit where you're not seeing as many cancer deaths anymore. And we have a 1% excess. And the trouble is that when we've had a lot of deaths in the old, then the deficit in the overall mortality can be hiding a problem in the young. And so that also needs to be investigated. What is happening with the young and what is happening with these rare cancer types, and is there a cause to look at here?
There certainly seems to be an increase in cancers of unknown origin, which again is odd, because most cancers, particularly with modern technology, you've got better and better able to work out where this thing has originated, what tissue it's originated. So they're just so vague, you can't say whether it was from the colon or the liver or it's just of unknown origin, which is very odd.
So Dr. Craig there pointing out that oncologists and doctors around the world are seeing a similar phenomena. If there's a similar new phenomena in many places around the world, is there a common cause? Is an obvious question. The cases of cancer, the stage it's presenting at, all these things, is it just coincidence, or is there some common factor in countries around the world? And even though there's not a great excess in cancer deaths overall, many older people have died in the pandemic and as a consequence of mismanagement in the pandemic. Therefore, we'd expect cancers to be less. So what we need is detailed breakdown in terms of age stratification and cancer types, especially unusual and rare cancer types. And the other doctor there talking was Dr. Ros Jones, who is a retired consultant, a very experienced consultant paediatrician. And she's saying that there's cancers now where it's hard to tell where the primary is. Now, what happens here is you have a primary tumour in one part, say in the colon, then that can spread to other parts of the body, say the liver, where it metastasises. But if you're finding a cancer that's already metastasised, it's unusual not to be able to trace it back to a primary origin tissue and saying, well, yeah, this started in the lung, or it started in the colon, or it started in the pancreas, or it started in the breast, or wherever it started. But if there's more cancers, as Dr. Jones seems to be perceiving there, that there's no clear origin, then again, that's a change in presentation and should be explained. Plenty more on this video now, but I think I might show you one more clip.
But when state services themselves are not differentiating as between harm and deaths, in particular caused by people that were vaccinated versus those that weren't vaccinated, how are we ever going to get to the bottom of it?
I don't know.
Well, I mean, the point is we could, right? You know, with cancer patients, we have biopsies and we have samples and we have tissue and we have evidence. What's the bit that's missing is the ability to test those things. But while we don't have that ability to test them, we do have the ability to store them for testing later. And so, you know, I think it's really important that we are storing them and that we start to set up the testing. We need to be testing and asking this question. Now, of course, it's a question people don't want to know the answer to. That's the problem.
Well, I agree with Claire, of course, but heck, I want to know the answer to it. So we can be doing biopsies, we can be taking tissue samples, we can be collecting evidence, and where we can't do tests immediately, these can be stored. And then this can be answered through more longitudinal data to give us definitive results. I still think there's things that need done as an emergency in the short term, but she's right, we need to increase testing, store the samples we can't test, we need a definitive answer on this. In the meantime, we should exercise the precautionary principle and first do no harm. Anything we're worried about should be suspended until we have complete scientific results. But if people are putting a blind eye to the telescope, they're not going to see very much. Let me know your thoughts, but we'll leave that one there for today. I will put the link so you can watch the whole interview there, the People's Vaccine Inquiry for Ireland, full of excellent, fascinating material. But for now, thanks for watching.